Hi, I'm Holly Tanner with the Herman and Wallace Pelvic Rehab Institute. I'm here with Tina Anderson and Kelly Sammis to tell us all about the new dry needling course. Hi to you both. Tina, do you want to start by introducing yourself and then we can hear from Kelly about just where you're practicing, a little bit about your background and such.
Sure. So, hello, everyone. My name is Tina Anderson, and I have been working in the realm of public health since I graduated from physical therapy school about 20 years ago. While I was in school, I had the good fortune to have a guest lecturer come in and discuss women's health physical therapy.
Mhm.
And after listening to that lecture by Eileen Kishman, I thought, wow, I'm a woman and seemingly know so little about how complex my body is and how it functions. And I need to do something about that. Not to mention that I grew up in a fairly modest household where the only words used to describe the genitalia was down there.
Mhm. That's
So
great.
at that time, I arranged for one of my clinical rotations to be in pelvic health, and I actually enrolled in a level one pelvic health continuing education course before I graduated.
Nice.
And ever since then, I've been engaged in pelvic health. I am currently living in Aspen, Colorado, and I have a private practice. And I've been practicing dry needling for nearly 16 years.
Nice.
Um, and just when I learned dry needling, I was just looking for alternative strategies to help improve my patient outcomes. And so I've taken several courses and I found that dry needling was just remarkably effective for improving patient outcomes. And this is the reason I began teaching it nearly 16 years ago.
Mhm.
So at that time, I guess dry needling was just really gaining a foothold in the US and it really was not widely used in the pelvic health world. So I started creating some techniques specifically to help the pelvic health population. And then I had the good fortune to meet my partner, Kelly Sammis, a brilliant person and clinician. And we have now created and are eager to teach the pelvic health dry needling course we are here to talk about.
That's fantastic. Is there a certain group of folks that you tend to work with? Do you see a lot of pelvic pain itself, or do you have a fairly well-rounded practice?
I have a fairly well-rounded practice, but I do see a lot of pelvic pain. I do see a lot of pudendal neuralgia. I see both men and women. I see urinary incontinence, low back pain. I really see the gamut, and I appreciate that piece because I think that keeps me on my toes in terms of having a global lens in terms of how I look at dysfunction in the body.
You bet. Well, thank you. And
Yeah.
Kelly?
Hello, everybody. Kelly Sammis. I live and practice just outside of Denver, Colorado. So I'm in a little burb called Parker. And I primarily see pelvic health dysfunction, female and male. A lot of my practice has become specifically surrounding pudendal neuralgia, so persistent pain, and in the realm of endurance sport. So I see a lot of cyclists, I see a lot of triathletes in the Colorado area, and just how that relates to cycling syndrome pudendal neuralgia is something that I see a ton in my practice. Otherwise, a lot of prenatal, postpartum, return to sport, just return to function. So I have the smattering of just my orthopedic type clients as well, but very heavy in pelvic health and in dry needling for pelvic health. I got into it, honestly, I had pelvic pain, and this was prior to having children. So I was already a clinician. I had been practicing for about 4 years at that time, started developing pelvic pain. It manifested to pain with intercourse, and I threw my hands up and I was like, what is going on? And instead of going to see somebody, because that would be, the rational thing to do, I enrolled in my first course
Good for
with
you.
Herman and Wallace. So
Nice.
I went to my first pelvic health course just to self-diagnose and realized that something that had been kind of manifesting for a long time as a persistent low back, kind of intermittent low back pain, sometimes SIJ, was really coming from my pelvic floor. And so it was kind of this aha moment that we had learned a little bit about it, like a 1 hour lecture in PT school, and never really revisited it. And it was kind of this moment where I realized I need to know more, because it was so influential for me personally, and that started my journey. And now, about a decade later, here I am. And so it's been a lot of fun because it started as almost like a personal exploration into something I was dealing with, and has turned into really my passion in PT.
That's wonderful. Well, and we're so excited that you both created this course for Herman and Wallace, and you've retooled the coursework a bit based on just what you've learned over time. And
Mhm.
so, in addition to having this course that is a foundational course, you've got a couple other uh, future courses that will be rolling out that build on the first one, but also have a bit of special population. So, would you like to either one of you talk a little bit about how you crafted this course series?
Sure. So, our course series, we broke it up to have two foundational courses. So, we did this really to give access to the pelvic health clientele or the pelvic health practitioner without needing any previous needling experience. So, these two foundational courses both have 8 hours of pre course content that covers the evolution of dry needling, the associated neurophysiologic mechanisms, how the intervention relates to our persistent pain, and then obviously covers safety and protection in regards to utilization of needle therapies. And then we touch very specifically on different pathophysiologic conditions and mechanisms that are specific to each course. So, our first foundational course is Dry Needling and Pelvic Health, our foundational concepts and techniques. And this focuses really on the lumbopelvic complex. It's geared towards more of your orthopedic clinician that wants an external approach to treating pelvic structures, but also for the pelvic health clinician who's interested in adding dry needling into their practice to complement other therapies that they're already utilizing. And then the second foundational course focuses more on pre and postpartum considerations in dry needling, with the pathophysiology focusing more on the pregnant and postpartum patient population. So in that course, our labs are geared a little bit more towards things like the cervical spine for like your headaches or your postural management associated with pre and postnatal periods. It looks at extremities for conditions like pregnancy related carpal tunnel syndrome, mommy thumb, plantar fasciitis, all of those different conditions that we see in our perinatal population. But both of those courses include a lab on the direct treatment to the female pelvic floor. And that is really it's the bread and butter of our course. And it is such an influential muscle group to treat, as most pelvic health clinicians realize, but it can be such an impactful region to treat externally. Like,
Mhm.
think about your clients that you can't do internal treat on, or that maybe have an adverse like a sexual trauma in their past to where they're not as open to internal based therapies, or your male clients who aren't really into the rectal approach. This gives you an external approach to these tissues that is hugely impactful in terms of seeing clinical results and really optimal function of these tissues. And both of these courses then funnel into our advanced techniques course. And then we do require that the clinician has taken one of the foundational courses because it focuses on more of our advanced techniques surrounding more sensitive structures in the thorax. So we really want clinicians to be comfortable with needle manipulation, being able to visualize 3D anatomy, just because of the sensitivity of the structures within that course.
Mhm. And Tina, can you talk a little bit about a big question that a lot of folks have, and that is the question about it being allowed in certain states, and what are the legalities or just the sensitivities that people need to have in terms of where they practice, the environment in which they practice. And following that, if you could talk a little bit about where it does fit into our scopes of practice as pelvic rehab practitioners, and perhaps if someone said, well, isn't this acupuncture? Right?
Yeah, absolutely. So every state has their own practice act, and I think it's very important that each clinician is familiar with their practice act. And practice acts are continually changing in terms of what can be performed, how it's performed. And so we highly encourage, each individual clinician to look up that information. The APTA is a wonderful resource in terms of identifying where their state is with regard to the legislation regarding dry needling. The majority of the states in the US do allow for dry needling, with the exception of Washington State, unfortunately, at this time, California, New York. Kelly, am I missing anything at this time?
Hawaii.
However, these states are possibly undergoing legislative changes, and it really does take clinicians to be familiar with what dry needling is and then advocate for that change within their own state to change their own practice act. So it is somewhat controversial in those states in particular. However, I think there will be a shift in the future. It just is a matter of time and education and understanding what dry needling is.
Mhm. And were you going to talk about acupuncture? Because I think that's sometimes where patients might get a little confused, and they can both be fantastic pathways, and a patient might benefit from one or the other or both.
Absolutely. I'm a big advocate of acupuncture, and I work collectively with acupuncturists in my community, which I think is a wonderful thing. It certainly, acupuncture is its own unique intervention, and of course, requires a very different pathway in terms of schooling to become an acupuncturist. Versus dry needling is, again, utilizing a needle. However, we're utilizing it in a different way with a different philosophy behind it. So, certainly, both can be meaningful tools and both can be used in conjunction with one another. I do not have any formal training in acupuncture. Therefore, I do not perform acupuncture. I perform dry needling, but I'm certainly an advocate of acupuncture. Kelly, do you have any comments on that piece?
Yeah, I would say one of the biggest differences is just the theoretical construct. It's looking at the evaluative techniques, and when you look at dry needling, we're basing it more off of musculoskeletal and neuromuscular presentations, patterns, and how that relates to overall function. And so
Mhm.
our tissue targets look a little bit different in terms of where we might choose to place a needle, if we use electric stimulation, and then kind of how we fit that into our entire spectrum of care looks a little bit different. And so, really, that's just based on the different theoretical constructs that the techniques are built upon.
Mhm. And I've heard folks say that it really has changed their practice in positive ways, and that we all might be really in love with some of our manual therapy techniques. And yet, practitioners say this really saves their hands. It really does help decreasing tone for patients. And patients also seem to really love it, even though you might think that it can be a little intimidating, perhaps when someone says, I'd like to do some needling. It seems that patients really also immediately see the potential impact it has. Has that been your experience as well? Is that there's just a real benefit including this as a part of a comprehensive plan of care.
Yeah, absolutely. Especially when you think about the depth of certain tissues that can be big, big players in dysfunction. Looking at treating something like the lumbar multifidus or the glute min, or an external approach into the obturator internus,
Mhm,
right? So it's nice because we can utilize the needle as a direct intramuscular tool,
mhm,
add the stimulation to it to where you see this beautiful reset of the tissue to a more homeostatic balance. And then we use all of our other tools to reinforce good movement patterns, to reload the tissues, just to get people back to function and to decrease pain when improving activity tolerance.
mhm,
I think also we really script the treatment in terms of how we manipulate the needle, where we place the needles based on the pathology that is in front of us that we're working with. And so it shouldn't look the same for every person, for every pathology. And so some people I think have this idea that, oh, it's this needle which seems threatening and it's going to be moved around in an aggressive manner in the tissue. And that's just not the case. So it's completely dependent on your treatment objectives based on the tissue you're trying to address and what's going on with that particular tissue. So it's certainly, again, it will fall along a spectrum in terms of what it looks like, what the experience is for the patient, and then, of course, just considering the patient tolerance to the tool. And
mhm.
the technique will always be modified to cater to the patient in terms of how they're responding to it. So I think that's an important thing to say.
And for folks who want to envision what this really looks like in the clinic, because someone might never have experienced dry needling themselves and are wanting to really have a sense of what this looks like in the clinical practice, can you give a description of what this does look like, sound like in clinical practice, in the sense of, well, we might do only dry needling in a session, and we might do 5 different locations, and they often take 2 to 3 minutes per location. And while they're having the needle in place, I'm doing pain neuroscience education, or like, what does it really look like in real time when folks might imagine coming to this class and then thinking about how it integrates into their clinic?
All right, I'll start. Yeah. So, for instance, again, I think when a patient comes in and we're assessing for dysfunction, right, where we create a hierarchy in terms of what we can do for them and how we think they'll respond. And of course, I don't always think it's helpful to do too many things in one session because then we can't determine, well, what created that change or that shift for our patient. And so For instance, if it's a patient with pudendal neuralgia, again, we might assess that, wow, yes, the left side of their pelvic floor is extremely reactive or hypertonic, if you want to use that word, and they're having a lot of pain associated with that piece. However, at the same time, I may need to address their hips and their lumbar spine. But let's start where I think I can maybe create the most significant change for the person. And that might be starting with their pelvic floor. And then of course, we're assessing, well, during what pelvic floor muscles were most reactive. And how is this patient going to respond? So it may be that I start with a muscle or two, maybe the urogenital triangle, transverse peronei, and puborectalis, depending on what I'm finding. Or perhaps I'm going to incorporate that with the sacral multifidi, thinking of the spinal connection piece to the pudendal nerve, which is S234. So based on patient tolerance, I would treat those structures, usually integrate some manual therapy. I always like the patient to go home with something. So perhaps whether it's some breathing techniques, whether it's some manual release techniques, whatever it is, and then we'll reevaluate when the patient came back in terms of what kind of change they had. And ultimately, we're really looking for not only to create change, but we want a sustainable change. And that's really important. So it's a step-by-step process. And every treatment session, it is evolving based on how that patient is evolving through that process.
And I think Tina said something that's really integral, and that's that it's not a standalone treatment. I mean, dry needling really, we tend to put it on the forefront, like at the beginning of the treatment, because it does lend us a beautiful reset of the tissue. So it gives us more of this window of opportunity to create change within the session. But then we have to utilize that window of opportunity to provide a patient with movement strategy, with mobility drills, and here's how you progressively reload the tissue to meet your goal, whatever that might be. And so if you look at like your standard treatment, let's say you have 45 minutes to treat, you're typically going to be assessing, palpating, deciding needle placement, and then actually applying the intervention for the first probably 15 to 20 minutes. And then in that time, you absolutely hit the nail on the head, Holly. You're doing your pain science education. You're talking through, did you have any questions on your home program from last week? Or just trying to do your patient education in that time. And then you're getting them moving, because that is the biggest piece. We have to get our patients active in their care. And that's really how we give them their autonomy in their health. And so I think that the way that Tina stated it, it's beautiful because it's not standalone. There's so many other pieces to that puzzle.
So, Kelly, why do you think people should come to this class?
Oh, why shouldn't you come
There
to
you
this
go.
class? Honestly, the availability of this intervention, especially for the pelvic health community, is so sparse right now. It's very regionally dependent. We have a great contingent here in the Denver metro area, but I have patients who travel in from out of state to see me for this because it's just not available in their region. And honestly, if you think about the spectrum of treatments available for our patients, especially those with persistent pelvic pain, from those that are more conservative to those that are more aggressive, this approach and where we land really as rehab clinicians is so conservative. And it should be something that we're trialing or implementing before we consider pharmaceuticals, procedures, surgically implanted devices. I mean,
Absolutely.
those types of things are so much more aggressive, and really they don't necessarily have the best track record for
Mhm.
successful outcomes.
Yeah.
And so if we can increase the availability of this type of intervention, it and just educate clinicians nationwide to start to implement it into patients' plan of care, it's going to be a game changer. I mean,
Fantastic.
especially for this population. It's something that Tina and I have really observed over the last decade plus in terms of meaningful and effective patient outcomes.
Well, I'm sold.
Yeah.
I have a
So
question for
come join
you.
us.
Because of the nature of this work and your interest in really supervising needle placement and technique and watching over folks as they learn this skill, you're going to do this course in person. These are live courses. And so what can folks expect in terms of how many times do you think you might teach the foundational course? I mean, are you gonna quit your day jobs and just teach this course series around the country? What might folks look towards in terms of where they might be able to get into some of these courses as you continue to schedule them?
Yeah, absolutely. No, we're hoping to offer this course at a minimum 4 times this year across the United States, so it's more accessible to practitioners depending on where they live. So that's going to be an important piece. And of course, we want to get our message out that it has so profoundly impacted our patient outcomes that it's worth examining and taking this material. And like Kelly said, I'm continually getting patients who are coming in and maybe they've had some success with some traditional interventions or pharmaceuticals, but they're really dissatisfied with the side effects of medications and they need something else just to help facilitate maybe a slightly different change or shift in terms of, where they're landing on that healing continuum or that healing spectrum.
Mm.
One thing about this course you had mentioned, what can students expect? We really highlight anatomy in this course. I think anatomy is a critical component to learn, whether you are obviously just a general practitioner or a dry needling practitioner. But with dry needling, of course, it's really important that you ultimately end up in the target that you intend to be in. And I just feel like reviewing anatomy just makes you a better diagnostician in general. Anatomy and neuroanatomy review is a huge focus of this course. And I feel like even after teaching for, again, nearly 16 years in the realm of dry needling, I still pick up some tidbit of anatomy when I teach, which is so meaningful to my practice.
Mhm.
And so,
Right, someone asks you a question, "Well, what attaches underneath this?" And you think, "Hmm, let me
right,
build that in my brain and
Mhm.
double check that," right?
absolutely, absolutely.
Fantastic. Well, thank you so much. We're really proud that you have chosen to work with us at the Institute and know that these courses are just going to be really beloved and that they're going to keep developing and people will probably find ways to ask you for other coursework on special topics. But this is quite a robust undertaking.
Mhm.
And again, we're really pleased that you are offering these classes. And I know that I think you had mentioned this first one is at capacity, is sold out.
Yes.
So don't delay. Get yours
Yes.
now while these seats are open, right? And so we look forward to seeing more courses on the schedule. And thank you so much for your time.
Thank you, Holly.
Yeah, thank you so much, Holly.
You bet.